the other lessons we've had so far, just relax and listen to the movement of the sphenoid bone as it goes into flexion. The greater wings or your thumbs will go away from you toward the feet, cauded direction, and in extension towards you. So that is the direction that you want to listen to. Sphenoid moving, the greater wings moving away toward your patient's feet in flexion as the body fills, and as the greater wings come back to you toward this head, cephalad, you want to feel that.
As the sphenoid and the occiput go through their normal or abnormal motions during each strain pattern. So when we are evaluating cranial strain patterns, we define our strains based on motions of the sphenoid and the occiput. In terms of where we're palpating, we end up palpating greater wings of the sphenoid and the squama of the occiput when we're palpating in vault hold. So in that position, this would be kind of our main position of palpation. And if we were to then illustrate or represent those motions that we're going to go over, the greater wings of the sphenoid and the occiput rotates posteriorly around a transverse axis above the foramen magnum. So in flexion, the sphenoid and occiput move like this, and then during extension, that opened motion closes up and might even exist on the left side. Okay. Our next physiologic strain pattern would be called a torsion. So if you think about the torsion terminology when you are describing sacrum dysfunction, the way we describe torsion is essentially a twisting motion where you have one direction and then the sphenoid rotates in the opposite direction. So both of the bones are going to be rotating in opposite directions around, in this instance, a single anterior posterior axis that goes through the foramen magnum and then through the body of the sphenoid. And now, how we're going to name those dysfunctions and we would call that a right torsion. In the opposite direction, we would feel the left greater wing of the sphenoid move superiorly, and we would call that a left torsion. It hasn't really sheared apart, and we kind of have a twisting motion around. The non-physiologic or pathologic strain patterns, essentially for each of these, we have abnormal motions at these this way and this way. So first, discussing a lateral strain pattern to rotate in the same direction around vertical axes. And again, our vertical axes are through the foramen magnum and through the body of the sphenoid. So they're rotating in the same direction around that vertical axis, and as a result are causing shearing force. You're going to palpate it in your hands. One description focuses on more of the shearing force, where if we're defining and kind of illustrating by our shearing force, we could right lateral strain where the sphenobasilar symphysis has shifted to the right, and we end up with a parallelogram towards the right. And a left lateral strain where they're rotating in opposite directions, and our parallelogram we would feel move to the right as our occiput swings laterally. Okay. Our next pathologic strain pattern that we're going to talk about is a vertical strain. So in this instance, similar. So first, we can have a superior vertical strain where both the sphenoid and occiput rotate anteriorly around transverse axes, and that transverse axis is through the base of the sphenoid and then above the foramen magnum. And we're naming this a superior vertical strain because of the direction that the base of the sphenoid moves. It moves superiorly relative to the occiput. And in the opposite direction, it would be an inferior vertical strain. Now, what would that feel like? What it would feel like due to kind of the motions of the greater wings of the sphenoid and for an inferior vertical strain where the base of the sphenoid is moving inferiorly because of that direction of the sphenoid and occiput, we could think of our hands coming this way. So this would be representative of an inferior vertical straight relief. The last pathologic motion pattern is a compression, which is essentially defined as restricted motion at the sphenobasilar symphysis in all directions of motion. So during both phases of flexion and extension, we essentially have very limited or no motion. So in flexion, there's not much motion. Extension, there's not much motion. Very, very small motions are palpated. And what ends up happening is we end up feeling that as kind of a stagnant cranium that feels very heavy.